Imagine this. You're out for a simple bike ride on a sunny Saturday morning. You slip on a patch of gravel, scrape your arm, hit your shoulder, and decide to get it checked just to be safe. 4 hours in the ER, a brief exam, a couple of x-rays, and a bill for $12,000 shows up in your mailbox 2 weeks later. Not long after, someone else wakes up with severe stomach pain. The doctor orders a CT scan to rule out appendicitis. Nothing serious, just irritation. But the scan alone costs $6,000. And then there's the 5-minute ambulance ride. 5 minutes that becomes a $2,500 line item. Stories like these aren't rare. They happen every single day to ordinary Americans doing ordinary things. What's shocking is that none of this shocks anyone anymore. It has become almost normal to brace yourself for the bill rather than the illness. And that's exactly where our story begins, with a question that millions of Americans quietly ask themselves every year, every time they open a medical bill they can't fully understand or justify. Why does the richest country on earth also have the most expensive healthcare system? And even more unsettling, why do Americans pay more than anyone else in the world while getting outcomes that often fall behind other developed nations? This contradiction sits at the heart of the American healthcare puzzle, and unraveling it means confronting some uncomfortable truths about how the system grew, how it operates, and why it costs so much. If you compare the numbers, the scale of the problem comes into focus immediately. The United States spends roughly $12,900 per person per year on healthcare, far more than any other country. Meanwhile, most European nations spend between $4,000 and $6,000. Canada sits around the $6,000 mark. Japan, known for its long life expectancy and efficient care, spends about $4,500. Yet despite paying nearly double or even triple the cost, Americans on average don't live longer. In many cases, they live shorter. Life expectancy lags behind much of the developed world. Rates of maternal mortality, diabetes complications, and heart-related deaths are significantly higher. The numbers paint a picture that feels almost upside down. Americans pay more, dramatically more, but don't necessarily get better outcomes in return. So how did the United States end up with this paradox? An extraordinarily expensive system that often delivers less than extraordinary results. The answer isn't simple, and it isn't the fault of any one group. It's the result of decades of decisions, incentives, and structures layered on top of each other. What emerged wasn't a system designed with a national blueprint, but rather a patchwork built piece by piece by hospitals, insurance companies, pharmacy benefit managers, and administrative networks, all operating with their own goals and pressures. And the administrative burden itself is massive. The paperwork, billing systems, coding requirements, and compliance structures create bureaucracy so large that sometimes hospitals employ more administrators than actual medical staff. All of these forces, profit-driven incentives, unregulated pricing, layers of intermediaries, and immense administrative overhead interact to push costs ever higher. This is the framework we'll break down in the rest of the video. But before we go deeper, it's important to sit with this first reality. America didn't build the world's most expensive healthcare system by accident. It built it piece by piece, decision by decision, year after year, until the price tag grew into something no other country even comes close to. And the bill, quite literally, arrived in the hands of the American people.
If the story of American healthcare starts with sky-high bills, then the next piece of the puzzle is even stranger. In the United States, patients are expected to shop for healthcare the same way they might shop for groceries or flights, except there are no price tags. Nowhere else in daily life do you agree to buy something without knowing its cost, but that's exactly how the American system works. You walk into a hospital, receive care, and only weeks later does the bill arrive. And until that moment, the price is invisible. You can call ahead, you can ask, you can try to estimate, but hospitals genuinely cannot tell you the real cost because the real cost depends on dozens of hidden factors. Which insurance plan you have, what network you're in, what your deductible looks like, and what contracts the hospital negotiated years ago behind closed doors. This lack of price transparency creates a system where the consumer, the patient, is blind. And a blind customer cannot make rational decisions. When people don't know the price of a product, when they don't know whether something costs $200 or $20,000, the seller can set the number wherever they want. That is exactly what happened in American healthcare. The absence of visible prices created the perfect environment for inflated, unpredictable, and often absurd charges. A simple lab test, a short consultation, a routine scan, each can cost wildly different amounts depending not on real cost, but on administrative contracts and corporate negotiations that no patient ever sees. This problem becomes even sharper when you look at the hospital landscape in the United States. In many regions, real competition simply doesn't exist. Instead, a handful of giant healthcare systems dominate entire states. These hospital monopolies grew over decades through aggressive mergers, acquisitions of smaller facilities, and consolidation that steadily reduced the choices available to patients. And once a company controls the market, prices naturally rise. They don't have to fear another hospital offering a cheaper MRI or competing for better value. In negotiations with insurance companies, they can set the terms aggressively, sometimes giving insurers an ultimatum: take this higher right or lose access to the only major hospital in the region. When one or two giants control every emergency room, every surgical center, and every specialist group for miles, patients have no leverage. The result is a system where a standard surgical procedure might cost $10,000 in one city and $50,000 in another only a short drive away, simply because the hospital market is structured like a monopoly. But perhaps the strangest part of this entire structure is something most Americans have never heard of: the hospital charge master. It sounds like the name of a sci-fi weapon, but it is actually the master price list that every hospital creates. This list includes tens of thousands of items, every test, every medication, every service, and unlike any normal marketplace, these prices are not based on cost or demand or national standards. They're simply numbers hospitals decide on. A bag of saline solution that costs a few dollars to produce might be listed at $150. A generic ibuprofen pill could be priced at $70. A simple bandage, something you could buy in bulk for pennies, might show up as a $30 item. The charge master is not meant to reflect reality. Instead, it's used as leverage during negotiations with insurance companies, a financial anchor that gives hospitals room to discount or inflate prices to maximize revenue. Even though very few people ever pay the full charge master price, it still shapes the entire pricing structure, and its influence cascades through every bill patients receive. And all of this unfolds within a broader system where hospitals, even nonprofit ones, increasingly operate like major corporations. Legally, they may be nonprofit, but economically, they behave with the same incentives as profit-driven companies, expanding market share, maximizing revenue, and reinvesting not just in patient care, but in branding, marketing, administrative layers, and luxurious facilities designed to attract high-paying patients. Executive compensation in many large hospital systems reaches $5, $8, or even $12 million a year. Massive teams of administrators handle billing codes, insurance claims, compliance rules, and negotiations with payers. And beyond that, hospitals invest heavily in high-end buildings, private suites, and state-of-the-art lobbies, features that may improve the image of the institution, but do nothing to lower the cost of care. In the end, these expenses don't disappear. They don't get absorbed by the system. They get passed down, quietly, invisibly, and inevitably onto the patients who never saw a price tag in the first place. This is the reality of a healthcare market without real prices, a system where hospitals act like corporations, middlemen shape the numbers, and patients are left holding bills that make no sense whatsoever. And understanding this business-first framework leads us directly into the next part of the puzzle: the hidden intermediaries who take their cut long before the bill reaches the patient.
If the business structure of hospitals explains part of America's healthcare cost crisis, the next layer is even more complicated and far more hidden. It lives in the paperwork, inside the insurance networks, and deep in the pharmaceutical supply chain. This is the world of middlemen: the insurance companies, the pharmacy benefit managers, and the administrative machinery that quietly adds enormous costs long before a patient ever reaches a doctor. And for many Americans, this is the part of the system that feels the most confusing, the most frustrating, and the most impossible to navigate. One of the biggest reasons is that the United States doesn't have a single health insurance system, it has thousands. Private insurance plans with different networks, employer-sponsored plans with different coverage tiers, government programs like Medicare and Medicaid, short-term plans, high-deductible plans, catastrophic plans, bronze, silver, gold tiers, and dozens of subcategories inside each one. Every plan has its own rules, its own exceptions, its own providers, and its own definition of what is covered. What this creates isn't just choice, it creates fragmentation. A system so split into pieces that coordinating care becomes its own full-time job, and the complexity itself generates cost. Every one of those plans has to be administered, billed, processed, audited, and negotiated separately, and that is where the hidden price begins. In fact, about 25 to 30% of all healthcare spending in the United States doesn't go toward doctors, nurses, medicine, or treatment. It goes toward administration. Not a small billing team, but vast bureaucracies inside every hospital. Billing departments with dozens of coders, legal compliance officers reviewing ever-growing regulations, coding specialists translating every action into a billing code, prior authorization teams determining if a patient is approved for a test. In many hospitals, the number of administrative workers now exceeds the number of physicians. That imbalance isn't accidental. It is the inevitable result of operating within a system that has been layered with complexity for decades. Every insurance company requires different documentation. Every billing code requires specific proof. Every appeal or denial becomes another loop of paperwork. And all of this overhead becomes part of the bill patients receive. But the administrative maze is only part of the middleman problem. The other, more invisible force shaping costs is the PBM, the Pharmacy Benefit Manager. These companies operate in the pharmaceutical supply chain, and most Americans have never even heard of them. Yet they are the gatekeepers for your medications. PBMs negotiate drug prices on behalf of insurance companies, decide which drugs are covered by your plan, determine how much you pay out of pocket, and collect rebates, essentially kickbacks, from pharmaceutical manufacturers. Those rebates are not small, they can be massive. And because the size of the rebate is often tied to the list price, PBMs have an incentive to push for higher list prices. Drug companies raise the list price, PBMs negotiate a discount, and both sides benefit, while the patient at the pharmacy counter pays the inflated number. This is one of the reasons why insulin in the United States costs 6 to 10 times more than in Canada. A vial that costs around $35 to $50 across the border can cost an American $300 to $350. And the same pattern applies to drugs like the EpiPen, asthma inhalers, specialty medications, even generics that should be cheap. The list price is inflated, the PBM rebate is hidden, and the actual cost to the consumer is anything but rational. A major factor behind these drug prices is the lack of national negotiation. Unlike Canada or the European Union, the US government historically did not negotiate drug prices on a national level. That means pharmaceutical companies set their own list prices, and the market simply adapts. On top of that, the practice known as patent evergreening allows companies to file small modifications, new delivery method, new dosage, new coding, to extend patent protection far beyond what the original patent intended. This delays generic competition, keeping prices high for years or even decades longer. And when generics finally do arrive, they often face strategic delays, lawsuits, or PBM formulary restrictions that limit how widely they're used. It is a system where innovation matters, but manipulation often matters more. The end result is a pricing structure that feels almost upside down. Drugs that cost pennies to manufacture end up costing hundreds at the counter. Medications that other countries consider basic essentials become luxury purchases in the United States. And the middlemen, insurers, PBMs, and administrative networks extract value at every stage, adding layers of markup that patients never see, never approve, and never fully understand. For many Americans, this is the moment when frustration turns into disbelief. How can a system with so many intermediaries, so many rules, and so much bureaucracy possibly work in the patient's favor? And that question leads us toward the final piece of the puzzle, the human consequences of a system built on layers of cost and complexity, and what it means for the future of American healthcare.
For all the complexity inside the American healthcare system, the deepest impact is felt not by hospitals, not by insurers, not by pharmaceutical companies, but by ordinary Americans. And this is where the story becomes personal. Because no matter who you are, where you live, or what insurance you carry, the consequences of this system eventually land at your doorstep. Across the country, millions of people live with the quiet fear of a medical bill appearing out of nowhere. Nearly 40% of Americans can't afford a $400 emergency expense, yet a single visit to the ER can exceed that within minutes. 66% of all personal bankruptcies in the United States involve medical debt. 1 in 4 Americans avoid seeking medical treatment simply because they're afraid they can't pay for it. And perhaps one of the most heartbreaking realities, many people actually avoid calling an ambulance in a real emergency, not because they don't need care, but because they're terrified of the price. These aren't abstract statistics, they are everyday choices that shape how Americans seek care, delay treatment, and weigh their health against their finances. And while patients struggle, the hospital landscape itself is shifting in ways that make care even harder to access. Rural hospitals are shutting down at an alarming rate, leaving entire communities without local emergency rooms, maternity wards, or even basic care. In urban areas, hospitals aren't disappearing, they're being absorbed. Large healthcare corporations buy up independent hospitals, physician groups, and specialty clinics. What emerges is a market where fewer and fewer entities control more and more of the system. And when consolidation rises, so do prices. A handful of large systems with little competition have no reason to lower costs. Instead, prices continue to climb, and choice continues to shrink. Meanwhile, ordinary Americans are left trying to navigate a maze that grows more complicated every year. The system is so tangled that even doctors who work inside it every day say it has become nearly impossible to understand. Prior authorizations delay urgent treatments. Surprise bills appear weeks after procedures. Pharmacies fall out of network without warning. Deductibles differ wildly between plans. Every form, every bill, every phone call seems to create another layer of confusion. The result? Patients don't feel taken care of. They feel lost. And even physicians, exhausted by bureaucracy, admit that the administrative burden takes precious time away from the people they're supposed to help. Yet, despite these frustrations, there are real conversations happening about solutions. Ideas serious enough to matter and practical enough to be implemented. Price transparency laws aim to pull back the curtain so patients can actually see what things cost before they receive care. Some proposals would cap the price of essential medications like insulin, ensuring that life-saving drugs aren't treated like luxury goods. Medicare has begun negotiating the prices of select drugs, a major shift toward aligning U.S. policy with other developed nations. Policymakers have also discussed limiting hospital consolidation to preserve competition. Reforming PBMs could remove hidden markups and shine light on the opaque drug supply chain. And there is a growing push toward value-based care, a model that rewards outcomes rather than volume, shifting incentives away from billing intensity and back toward patient health. These ideas don't solve the problem overnight, and none of them are a magic fix, but they represent something this system has been missing for decades: a sense of direction, a recognition that costs didn't explode by accident, and they won't fall by accident either. Real change requires real incentives, real transparency, and real accountability. And that brings us to the final point. To understand why American healthcare is so expensive is to understand how we got here. A system built piece by piece, not designed from scratch. It grew through layers of decisions, negotiations, loopholes, incentives, and middlemen. And until the incentives change, the results won't. The bills won't. The pressure on American families won't. But knowing the truth is the first step towards changing it. And maybe, just maybe, towards building a system that finally puts patients first.